Welcome, and thank you for joining us for today's session, Frequently Asked Questions on Multiple Myeloma Precursor Conditions. I'm Veronica Borges, Manager of Patient Education at the Multiple Myeloma Research Foundation, filling in for Mary Jerome. I'm joined today by Dr. Shaji Kumar from the Mayo Clinic in Rochester, Minnesota. We've invited him to answer some of the frequently asked questions we receive from patients and caregivers about the precursor conditions, monoclonal gammopathy of undetermined significance, or MGUS, and smoldering multiple myeloma. So Dr. Kumar, we're going to begin with a few questions focusing on diagnosis. And so to start off, Dr. Kumar, we often hear about MGUS or smoldering myeloma patients who have relatives that had myeloma or some other type of plasma cell disorder. Can you tell us what the familial link is between myeloma and its precursor conditions?
That's a great question, Veronica. I think this is something that always comes up in the clinic. My relatives at an increased risk. And we often hear about patients in the clinic who says, oh, my brother had it, or my aunt or uncle had it. What we know from the studies that have been done is that first-degree relatives of patients with myeloma or any of the plasma cell disorders have about 2 to 3-fold higher risk of getting a plasma cell disorder compared to the general population. Now, even though that 2 to 3-fold risks appears like a substantially higher risk, when you think about the overall frequency of these conditions, the rare disorders, the absolute risk of you getting it is still far, far lower than a lot of other common clinical conditions that one might get during the lifetime. So now, why does it happen? We don't entirely know why. We have not been able to identify a particular genetic link that is inherited from amongst family members. It's quite possible that it more than it's a combination of a genetic aspect as well as shared environmental exposures, such as growing up in a same household, being exposed to similar environmental agents that we know some of, especially things like pesticides, petroleum products, all of which we know have been linked to an increased risk of getting plasma cell disorders. So I suspect it's a combination of genetic and environmental factors, but clearly there is a increased predisposition within families. But again, I think it's important to highlight that this is very, very small in terms of absolute risk.
Thank you, Dr. Kumar. So you touched a bit actually upon patients that are potentially, or those are living in the same home and these environmental factors. So as a follow-up, for people that have a first-degree relative that has myeloma or one of these precursor conditions, are these individuals at higher risk of having a precursor condition? And should they be seeing their primary care doctor more often than normal so that they can catch a diagnosis sooner?
Right. That is a question that we are continuing to work on finding the right answer for. The simplest answer right now, when you ask, should a family member be screened for a monoclonal protein, given that it's a simple blood test, in case, the simple answer to that is no, because again, we're talking about a condition that is relatively rare, despite that increased 2 to 3-fold higher risk, still remains a very, very low probability that a given person would have a monoclonal protein in their blood or urine. Now, having said that, there are two important aspects, with the monoclonal protein or the monoclonal plasma cell disorders. One of them is obviously the increased familial risk that we talked about. And the second is the increased risk that we see in certain populations, right? So we know the African Americans have 2 to 3-fold higher risk of getting monoclonal plasma cell disorders. Now, when you put two and two together, if you're talking about an African American individual who has, let's say, 2 siblings who also has monoclonal gammopathy, that is a situation where we think we should probably screen by doing a blood test, because now you multiplying that 2 to 3-fold higher risk by another 2 to 3-fold higher risk, and then it gets to a point where I think it's worthwhile knowing if somebody has it. And again, I think it's also important when you screen for something like this. The average age of an individual identified with a monoclonal protein is in the 60s, and we believe it probably starts somewhere in the 30s. So it takes 15 to 20 to maybe 30 years to get to a point where it's large enough to be detected. So if you do it sometime very early, you may not even find it. So it may be more applicable when you start screening people beyond the age 50. In fact, we are looking at some studies, particularly using some of those very sensitive tests like the mass spectrometry based testing for the monoclonal protein to see, is there a particular age where we can screen, and a negative test might predict that person will never get a monoclonal protein during their lifetime.
That's very, very insightful, Dr. Kumar. That's a great kind of segue, I think, into our next question. So what is the difference between MGUS and smoldering myeloma? How is this diagnosis made, and are bone marrow biopsies involved?
Right. So when you think about this whole spectrum of monoclonal plasma cell disorders, amongst all these is the fact that you have increased numbers of plasma cells that are dividing without the normal controls that are put in place. Typically, the plasma cells would multiply when they are exposed to an infectious agent or some kind of a foreign substance. It reacts to that by increasing in numbers, takes care of the issue, and then kind of wither away. And so you don't have necessarily something left behind each time you are exposed to something. But in the setting of these monoclonal plasma cell disorders, now you have a plasma cell or a set of plasma cells that have kind of gotten abnormal. They continue to divide, continue to increase in numbers, and it's a spectrum starting at one end with what we call a monoclonal gammopathy of undetermined significance, or MGUS, where these plasma cells have increased in numbers. They do make some protein, but again, the percentage of the plasma cells is less than 10%, and the protein that they make, or the M spike, is typically less than 3 grams. Now, at some point in time, they could cross those thresholds, and now you have maybe 11% plasma cells, or 12% plasma cells, or 20%. Or you could have an M spike that is now 3.5 grams, or light chain in the urine that is almost 500 milligrams or more over 24 hours. So once you cross those thresholds, now you call them smoldering multiple myeloma. One might ask, why do we have this kind of very artificial line in sand, so to speak, right? And part of the reason why these definitions were created was because we know that if somebody has crossed those thresholds and now are at the smoldering stage, their risk of moving on to active myeloma or progressing to active myeloma is much higher than somebody who has monoclonal gammopathy of undetermined significance. Now, is the risk for somebody at 3.1 much higher than somebody at 2.9? No. It's a gradual increase in the risk, but we had to draw the line somewhere so that we have, those group of people can be put under closer surveillance so that we pick up the progression at as soon as it happens, rather than checking them less often as we would do in the setting of MGUS. So that nomenclature of MGUS versus smoldering has been primarily put in place to decide how often do we need to follow somebody up so that we can find it at the right time before it actually gets to be active myeloma.
Thank you, Dr. Kumar. That touches a little bit also kind of in our next question here. So you touched a little bit briefly on the criteria between MGUS and smoldering, or patients that potentially fall into these categories. So this is sort of a two-parter. Do you know what percentage of MGUS or smoldering progresses into multiple myeloma? I know you touched a little bit on that in your previous answer, but also, at what point is MGUS or smoldering myeloma considered myeloma?
Right, that's an important question. So in terms of the risk of progression, when you look at the patients who have a MGUS, their risk of progression is roughly about 1% per year. And it's very interesting phenomenon because it's a very constant number. So if you have 100 individuals with MGUS that you're following on an annual basis, every year, 1 out of that 100 would go on to get active myeloma, roughly. And this percentage doesn't really change over time. So in about 30 years, if you've been watching those 100 people, roughly about 25 of them would have gone on to get myeloma or something that's related. Now, there are certain characteristics within that in each individual, depending upon what type of monoclonal protein, what type of light chain levels, all those things can have an impact on that risk, but the average is about 1% per year. Now, in contrast, when you look at those people who have crossed those thresholds and now they have a smoldering myeloma, those individuals, the risk is different. If you take 100 people with smoldering myeloma that was diagnosed today, in the next 5 years, there will be about 50 of those 100 people who would have gone on to get active myeloma. And in 5 more years after that, another 15% may have gotten myeloma. But once you go beyond that 10 to 15 year mark, then the risk of progression becomes almost 1% per year, just like the MGUS. And this again highlights that something very fundamental to these definitions, which is smoldering myeloma is really not a distinct entity. You can really think about it as you have myeloma or you have a precursor phase. That definition of smoldering was primarily created so that we can identify those people who are at the higher risk of kind of gotten closer and closer to myeloma, so that we can watch them much closer. So typically somebody with MGUS, we would watch them once a year. Somebody with smoldering, we would watch them once every 3 months or so because of the increased risk. And again, these are general guidelines. As I said before, somebody with a 3.1 gram M protein and somebody with 2.9 grams, even though they're called different things, we might elect to watch them in a very similar fashion.
Excellent. Thank you, Dr. Kumar. Touching upon these pieces and the progression, we're going to talk a little bit also potentially about risks. So is there a way to tell which MGUS or smoldering myeloma patients are at the highest risk of progression to multiple myeloma? And as a follow-up, does the Pangea model that we recently heard about on our precursor conditions with updates webinar have anything to do with this?
Absolutely. Now, going back to your previous question, one thing I did not address is just talking about what distinguishes that active myeloma from smoldering myeloma. And there's been criteria that have been developed to say who has active multiple myeloma. In the past, so before 2014, we relied on what we called CRAB features, meaning somebody has high calcium levels, their kidneys function has had some change, they have developed anemia, or they have developed bone disease. Now, obviously, we would like to catch people before they develop any these kind of clinical symptoms and signs, particularly bone disease, which puts individuals at risk for breaking the bone or having some catastrophic events like compression of the spinal cord or the kidneys shutting down. So what had happened in 2014 is we were able to identify some specific what we call biochemical or biomarkers that allowed us to predict who is going to get the CRAB features in the next couple of years. And those included people with a free light chain ratio that is over 100, that is a blood test that you do in the blood, looking at the free light chain levels, or looking at their imaging studies to see if they have MRI detected lesions, which are not destroyed bone, but changes in the bone marrow. And obviously, if they had 60% or more plasma cells in the bone marrow. So any of those 7 characteristics, the 3 that are picked up on testing and the other CRAB features, would identify somebody whom we would call active myeloma that needs treatment. Now, going back to what are the risk factors, right? So there's a whole bunch of different risk factors that have been identified. Obviously, the quantity is one of them. So if you have high M spike, if you have high levels of free light chain, abnormal free light chain ratio, whether it's a kappa to lambda, lambda to kappa, whichever is the involved light chain. If you have high plasma cell percentage, all of this denotes to some extent, something that has progressed and there's a lot more of those abnormal cells. But then there are also characteristics that are more related to how bad these cells are, which would be to some extent, what kind of cytogenetic or genetic abnormalities these plasma cells carry, whether these patients have, again, larger number of these plasma cells in the bloodstream. Are they suppressing the normal immunoglobulins? And all those things can also impact the risk of progression. So what have been attempted over the years is to develop systems or scoring systems that would give a specific score to a given scenario or a given patient to say, yes, your risk of getting myeloma in the next 5 years is X percentage. That's kind of what has driven how closely we might follow a patient, and we might talk about later on whether we would actually treat some of those people. The most commonly used risk scoring system for smoldering myeloma is what we call the 20 to 20 staging system, which was originally developed at Mayo Clinic and subsequently was validated in a large cohort of patients by the International Myeloma Working Group. Now, that was a model that was developed primarily in the smoldering myeloma patients and is primarily intended for use in smoldering myeloma. So if somebody is considered to be having a low score now, but if they become high score, let's say a year later, the risk of progression would have gone up at that point in time. So it is something that can be used multiple times during the course over years. What are the numbers mean? So the 20 to 20 stands for 20% plasma cells in the bone marrow or more than 2 grams of M spike, or a free light chain ratio that's more than 20. If you have two of those three characteristics, then your risk of developing myeloma is roughly 50% in the next 2 years. Now, the there's more kind of a more granular version of the same 20 to 20, where instead of just using one cutoff, we can use multiple different cutoffs to develop a score. So if you were to use that, and that includes cytogenetic abnormalities that you see on the FISH testing, then you can have a score of up to 16. So any score over 12 denotes almost a 70% risk of progression at 2 years from diagnosis. So that gives you a little bit more nuanced, instead of just saying you have a risk of more than 50% at 2 years, you can say you have 20% risk or a 40% risk or a 60% risk at 2 years or 5 years. So it gives you a little bit more accurate numbers. Now, the Pangeo model is something that was developed more recently, but that was developed primarily in a combined group of MGUS and smoldering patients. So it's hard to compare that model with 20 to 20 and cannot be applied in individual populations like smoldering or only the MGUS. It's something that is used for everyone that is pre-myeloma, so to speak.
I see. Thank you, Dr. Kumar. So thank you for explaining also the 2220 criteria. To follow up on this criteria that's utilized in assessing risk, if a smoldering myeloma patient falls under the 2220 criteria but has been stable for 10 years, is this considered low risk or not? And that is, does the length of time someone has lived with their precursor condition factor into whether you would consider a clinical trial for treatment or not?
Absolutely. I think it's a very, very important point because, as I said, the smoldering, is kind of a mixed bag of MGUS and active myeloma, and it takes us almost 10 years to kind of weed them out, kind of separate out those two from within that group. So if you haven't progressed by 10 years from the diagnosis of smoldering, your risk of progression is almost the same as a MGUS patient. So once you get to that point, then we would consider maybe less intense follow-up. So initially we would follow patients every 3 months, maybe after 5 years, if nothing has changed, we can maybe follow them every 6 months for the next 5 years. And if nothing has changed still, we could reduce the follow-up frequency to every year. Now, having said that, stability for 10 years doesn't necessarily mean it cannot progress anymore. Things can change. So I think the less intense follow-up, but still regular follow-up is important to make sure that we don't miss out on these individuals progressing to myeloma.
Excellent. So monitoring is certainly a key, it plays a key role for MGUS and smoldering patients. So Dr. Kumar, what can MGUS and smoldering myeloma patients expect regarding their care and follow-up after a diagnosis is confirmed?
Yeah, I think the key thing with the follow-up is, with MGUS patients, the first time you diagnose the monoclonal protein, we clearly want to check that in 3 to 6 months to make sure that we didn't just capture something as a snapshot and something was just continuing to go up. Once we kind of confirm that some things are stable over 3 to 6 months, then we can, if they have MGUS patients, it's once a year. And even within the MGUS patients, there's significant, there can be risk stratification, which tells us certain people, the risk might be really low, that we could follow them maybe once every 2 to 3 years, and others may be at a higher risk, and we follow them maybe every year. And that determination is again based on some of these characteristics like the M spike size, the free light chain ratio, and so forth. So for the so once the MGUS is identified, the first thing obviously is to make sure the diagnosis is really truly MGUS. Sometimes you can have people with low levels of monoclonal protein who may have other associated conditions like light chain deposition disease, where the kidneys can be affected, or amyloidosis, which can affect a variety of different organs. So we do want to make sure none of those conditions exist at that point. Once we are convinced that this is truly MGUS, then it's a matter of just following them. Now, there have been a lot of other disease associations that have been described. Sometimes people with monoclonal MGUS can be at higher risk of getting infections, more risk of developing osteoporosis. Now, we don't know how strong these associations and how much of it is cause versus effect, and whether they're just associations that just happen to go together with age. So I think it's important that the primary care physician, ensures that the routine things that we do on an annual basis for individuals is continued to be done for these individuals as well. Now, obviously, if you have a smoldering myeloma, in addition to obviously following all these markers much more closely, we should always need to be having an eye out for any clinical signs or symptoms that might indicate that the disease is progressing now.
Excellent. Thank you, Dr. Kumar. So now we're going to transition a little bit and talk about treatment and prevention with precursor conditions. So, Dr. Kumar, patients are sometimes surprised to hear that there is no need to treat MGUS and smoldering myeloma. Why is this the case?
It is, I would say, more difficult to tell the smoldering patients or the MGUS patient that we are not going to do anything about it from a treatment than to tell a myeloma patient that this is a treatment that we're going to give you. And I think part of it is, it's just human nature that we identify something is wrong. We need to do something to fix it. But it's not just MGUS. I think we encounter this in a variety of different hematological cancers, and even in others too. It's like prostate cancer, for example, where we know that a significant proportion of people, it will never get to a point where it actually is going to do any harm or shorten people's lifespan. And the treatments at the same time come with its own baggage of side effects. So there's a real possibility that if you were to take that example of 100 patients with MGUS we talked about, 70 of them never getting to a point where they need treatment for their monoclonal gammopathy. So if you were to treat all those 100 people, 70 people would have gotten treatment for no good reason. And these medications are not without side effects. Now, it's always a balance between risk versus benefit, right? Tomorrow, let's say if you have a drug or let's say natural supplement that is going to bring the M spike down with almost no side effects, then we can say, sure, let's treat all those MGUS patients, individuals. But that is not the case today. And the treatments we use for smoldering, for example, is the same as what we would use for, or often are drugs that you use for treating myeloma and come with its own side effects. So we want to make sure that we only give it to patients where the risk is high enough that it actually provides a meaningful benefit. And that's where many of these risk scoring systems come into play, so that we can take those smoldering patients, say this is the 50% of the patients who are at a high risk of progression over the next 2 years, and let's do something about them. Of course, we don't want to do that in the absence of any data supporting it. Thankfully, we have 2 large phase 3 trials that have shown that if you treat patients with high-risk smoldering myeloma with either a drug like lenalidomide or lenalidomide with dexamethasone, you actually can not only delay the time it takes for people to develop myeloma, but as the Spanish trial has shown us, people actually do live longer. Obviously, there are lots of ongoing trials answering a variety of different questions that we don't know the answer to, which is, in addition to just treating these people, what should be the treatment? And should the treatment be modified based on their underlying risk? So somebody who is much closer to myeloma, maybe we treat them like myeloma. And somebody who's more closer to MGUS, maybe we treat them with something much less intense.
Excellent. Thank you. Very insightful. And then I think that kind of turns us to our next question. So as patients are being as active as possible with this diagnosis, are there any signs or symptoms that MGUS and smoldering myeloma patients should be sure to mention to their doctors that might be relevant to their disease or possibly a sign of progression? So, for example, many smoldering myeloma patients ask if having osteoporosis is a CRAB feature of myeloma.
So osteoporosis per se is not a crap feature because you can have osteoporosis that's just associated with age. So if you have a 70-year-old individual with some osteoporosis, we won't worry as much that the plasma cells or the MGUS or the smoldering myeloma is responsible. However, if you have a 45-year-old with significant osteoporosis, then we really worry that that plasma cell clone is really doing some damage here. But typically, when you talk about bone disease, we are talking about lytic lesions, which are basically holes in the bone that is created by these collections of plasma cells eating away at the bone. So, I mean, in terms of symptoms, the general principle that I always tell patients is if you develop a symptom that is unusual and doesn't go away, make sure you tell your physician to have it evaluated. But the typical things we would worry about is somebody developing bone pains, frequent infections, or a fracture with very little trauma. Or somebody notices that they're becoming anemic. Or again, it's all not just myeloma, right? Some people can develop amyloidosis. So if you start getting short of breath, if you start having swelling in your feet, or if you start bruising easily, or numbness and tingling in your fingertips or toes indicating neuropathy, all those things could indicate, again, the underlying plasma cells doing mischief, but not necessarily fall into that bucket of myeloma.
Excellent. So these are helpful kind of pieces for patients to consider as they're navigating. So great. So we're going to talk a little bit about actually treatment now. So Dr. Kumar, following up on treatment, if the rationale for not treating MGUS or smoldering myeloma patients is due to sparing them the potential side effects of treatment, which you touched base on a little bit earlier, what are some of the potential specific side effects that come with starting myeloma drugs early? And can you describe what these potential side effects are?
Absolutely. Of course, it depends on what type of treatment that we use. So if you're talking about the 4 commonly used drugs used in either combinations of 2, 3, or 4 drugs in a patient with newly diagnosed myeloma, then we are talking about a monoclonal antibody like daratumumab and medication like lenalidomide or Revlimid, something like bortezomib or Velcade and dexamethasone. So with daratumumab, again, there can be infusion reactions that are associated with it. It does suppress your immune system to some extent and increase the risk of infections, especially when given over a long period of time. It can be associated with quite a bit of fatigue in some patients. The Revlimid or the lenalidomide can be associated with the drop in blood counts. It can cause increased risk of blood clots. Long-term treatment with that might be associated with increased risk of getting other cancers. You can have chronic GI gastrointestinal disturbances like diarrhea associated with long-term Revlimid therapy. With bortezomib or Velcade, you can develop peripheral neuropathy. It can also increase risk of infections. It can drop your platelet counts, often just transiently. And with dexamethasone, it can be again increased risk of infections, weight gain, difficulty sleeping, and so forth. So these are kind of the major side effects, but all these drugs can be associated with much rarer side effects as well.
Thank you, Dr. Kumar. So most of our patients are very keen, again, focused on treatment, but of course it does not necessarily mean that treatment sometimes is always applied. However, if patients are just monitored over time for signs of progression and do not receive any treatment, is there any data to support a certain diet or lifestyle that may be of help in preventing progression to myeloma?
Yeah, it's a question that comes up all the time. We don't have anything that has been scientifically proven to slow down the rate of or the risk of progression, either diet or exercise.
Bless you, Dr. Kumar.
Thank you. Having said that, I think it's important to have a good, healthy diet and also make sure there's plenty of exercise as part of your daily routine, because it is, these aspects, they're not particular to or specific to MGUS. These are things that will be good for a variety of different conditions and overall health, and also just longevity in general.
Excellent. Thank you. So we're kind of here almost at the end of our conversation here. So kind of just as a concluding thought, I'd like to ask you kind of this final question. So how best can patients with MGUS or smoldering myeloma cope with their diagnosis? It has to be very stressful knowing that you have a disease that may eventually progress to multiple myeloma, but at this time, there is no treatment outside of a clinical trial. So Dr. Kumar, the floor is yours.
Yeah, it is always the most challenging discussion that you have, right? I think it's hard to tell someone that there's a sword hanging over your head, but we just don't know when it's going to fall. But I think, again, explaining in detail the whole concept of, what could be the benefit, what is the risk. I think that one is explaining that the actual risk to the patient and the probability that they might ever end up in that situation is I think the first important step. The second important step, I think, is the reassurance that we're going to be watching it closely, and watching it closely enough that it's unlikely. We can never say 100% that we will be able to catch everything on time, but close to that, we'll be able to identify when things are getting bad. And then the other aspect of our reassurance is that even if it does get to a condition like multiple myeloma, we have so many new drugs that are so effective in controlling this, that the myeloma itself is no longer the death sentence it used to be a long time ago, and it is something that we can actually treat, and hopefully in the coming years we can be confidently say that it's more of a chronic disease rather than a fatal cancer.
Well, thank you, Dr. Kumar, for your time today. That kind of wraps up our Facebook, YouTube Live. So on behalf of the MMRF, I'd like to thank Dr. Kumar for joining us today and for his great detailed answers to many of our questions. I'd also like to thank everyone for taking time out of your day to watch. Finally, I'd like to thank our partners, Adaptive, Genentech, GlaxoSmithKline, Janssen, Karyopharm, and Takeda for sponsoring this session. This Facebook Live and YouTube Live will also be made available as a recording on the MMRF's YouTube page and our website. If you have any additional questions about what you heard today, please call our MMRF Patient Navigation Center at 1-888-841-6673.